A warm welcome to all our Physio TV viewers. We come yet again with another very exciting talk. And this time, the faculty who's going to take a talk needs no introduction, but I'll still be going ahead and doing the honor. We have with us today Dr. Asha Menon. Dr. Asha Menon is going to talk on the role of McKenzie method in treatment or management of the chronic low back pain. Dr. Asha Menon ma'am has graduated in physiotherapy in 1989 from St. G.S. Medical College, Mumbai. In 2012, she completed her clinical training in NHS Scotland as part of her postgraduate diploma. She's been a pioneer to bring the world famous McKenzie concept to India, which is one of the most widely used method in treating mechanical orthopedic pain in the spine as well as in the other joints. In 2013, she was the first Indian to be accepted as a probationary faculty and now as a faculty for the McKenzie Institute International New Zealand, and is also a faculty and examiner at the International Credentialing Examinations, which are held in India for Indian physiotherapists by the McKenzie Institute International. She has presented various lectures on the McKenzie concept in conferences, universities, medical organizations, as well as for the general public. She is a published author and has to her credit research papers in peer-reviewed journals and local medical journals. She's been a private practitioner in Mumbai and also clinically practices as a part of network of the accredited McKenzie clinics around the world and is a part of the global network. She's established her first clinical principle of the certified McKenzie clinic at a tertiary hospital in Bharatiya Arogya Nidhi Hospital at JVPD in Mumbai, and also has been an official representative of India at the McKenzie Institute International, New Zealand. She's organized 23 international courses, 4 international credentialing exams, and 1 clinical skills update from 2008 till 2012. She's also been an executive director and a founder director of McKenzie Institute of India from 2012 till date, and has been responsible for incorporation of McKenzie Institute India as a company for charitable purposes for the benefit of patients with various musculoskeletal disorders in India. She's an executive committee member. She has been an executive committee member at Physiotherapy Private Practitioners Group, founder committee member at Manipulative Manipulation of India, and also a member of the physiotherapy, the Bombay branch of Indian Association of Physiotherapy. Sorry for that. She's been awarded the Academic Achievement Award for significant contribution in the field of physiotherapy at World Laparoscopy Hospital, Gurgaon on 9th April 2017. Apart from chairing various scientific sessions and conferences, she's also given a lot of lectures in India and abroad about the McKenzie concept. She's also been called as a host as well as a scientific presenter in upcoming conferences. I now pass the session on to you, ma'am. We are very honored to have your talk today.
Thank you. Thank you very much, Dr. Sona. It's been a pleasure always connecting with Sancheti Hospital. And I've had very good, happy memories when I've come to the Institute. And every time that I have connected with your awesome academic team there. And yes, I've had the pleasure of having Sancheti students as my assistants and also as students for the McKenzie concept. And they have always come out as one of the brightest. So kudos to your whole team for bringing out such wonderful physiotherapy students. So I'll share the screen now.
Over to you, ma'am.
Yeah, thank you so much. So I would now start and begin with role of McKenzie method in chronic low back pain. And thank you so much, Sona, for the wonderful introduction. Since 2012 to 2022, we have increased the number of courses and the exams that you mentioned. And it's, I would need to really count it for updation. So going to the next slide. Okay. So when you're talking about chronic low back pain, does definition in time really describe the reality of this group of patients? The first thing that we would need to do in this group of patients is, yes, as always, rule out a red flag. But after that, we would need a biopsychosocial model in this group of patients. So let's look a little further at how the McKenzie method identified these in the management and before that in the evaluation. So as per Waddell, he has very clearly said clinical impression and psychological studies suggest that patients who accept personal responsibility for their pain do better. And this has been based on research evidences and clinical impressions. And so what does it tell us? That a very active patient involvement is needed for this group of patients rather than doing things passively on the patient. So when we would do passively things on the patient, it would only make them dependent on the clinician and also support an illness behavior in the patient, which would already probably be inherently there in the patient. And MDT, or the McKenzie method, which is also called as mechanical diagnosis and therapy, in short form, we can call it as MDT. It incorporates an ADTO model. So what is an ADTO model? It means that, very contrary to the misconception that McKenzie is extension or McKenzie is disc and McKenzie is derangement, it actually starts with a very structured assessment, which culminates in a diagnostic classification and a management which is very specific to the classification. So it is a tailor-made management for each patient. And we would, during this, incorporate within the structured assessment, we would be identifying these various flags that may be present inherently in the patient, and further to which the management would be done. And this would ultimately give us outcomes which are very predictive in nature. We have directional preference and centralization as part of the clinical assessment, which is also known very much as outcome predictors or prognostic indicators. And so we can say that the McKenzie method is not just techniques, but it is a very comprehensive system which includes assessment, classification, treatment, which identifies the various drivers of pain and disability within the assessment for appropriate application during the management, and includes prophylaxis as within it the system. And so we can say it's a very dynamic and a comprehensive system. So if you are looking at the efficacy of any management system for low back pain, we have got to first see what does it have to offer to chronic low back pain group, because this is a very big group. Does this incorporate within this assessment, does it identify this various flags, the drivers of pain and disability? And what would it do in the management system to counter these? These have to be seen before we would want to see which is the best system of management. So if we were to see the research evidences, no system has really topped that list there, or as the, let's say, the best system. You can't really say there's nothing as a best system. But yes, we are looking at which systems have got robust evidences for identifying these and treating these subgroup of patients. And yes, the McKenzie method has got a very robust research evidences to itself. So we would incorporate the biopsychosocial system, and it's a very active patient involvement. How is it a very active patient involvement? Right from the history taking, we would be using very open-ended questions involving the patient in the history. When we come to the physical examination, we would be involving the patient because there is a repeated movement testing, which is the litmus test that we would say in our structured assessment that helps us to classify the patient. And in the repeated movement test, we would be getting the patient to repeat movements. When we repeat movements, we are also countering the fear in the patient. The fear in the patient for movement the fear in the patient for thinking that the illness behavior or that one particular moment may probably worsen them. So we involve the patient, there is a talking to the patient at all times, at all stages throughout the assessment. There's also a very active patient involvement because there is a philosophy of patient empowerment, be it during the assessment. So if there is a patient who is repeating flexions and the patient already thinks that flexion is wrong or flexion is going to be damaging to the spine, we would show that how the repeated flexions probably in that particular patient that we have been evaluating has not really increased the symptoms in the patient distally or even proximally. And this is shown to counter the fear that may be there or the depression that the patient cannot move and cannot go back to full functions. So at all times there is a talking to the patient, as also during the post the evaluation when the patient is left with a home program, there is a lot of empowerment that is given to the patient to help them to identify when till the time they come back to us, if there were to be ups and downs in their symptoms, how are they going to identify why were there ups in the symptoms and how can they counter it. So there is a very active patient involvement and an empowerment which will only help them to improve on the beliefs that they have, the coping strategies that they have, which will ultimately get them to go back to normal functions and back to work early. So we would also, there's a specific patient education which starts right from the time the patient has started with where we are handling the patient with history taking. Right from there, we are checking out to see whether the patient, what is the patient's status in terms of a learning. Is the patient ready for a change? So we would get the patient from I'm not ready to change to yes, I think I should change, to yes, I'm beginning to change, yes, I have changed. So they are going to be empowered throughout and going to be taking a positive decision-making process will be there with them. So it is a clinician and a patient is working in partnership. So there's a very specific education depending upon what is a patient's learning style and what is a patient's learning stage. So the McKenzie method is full in its kitty where we can tackle different learning styles. And so it's only when you tackle the different learning styles in a patient will you be able to educate the patient to get themselves empowered or even to self-manage. There's also active patient involvement because there is a philosophy of self-management. So whether it is during the treatment, when there is ups and downs, they learn to problem solve and they learn to get themselves reduced with their symptoms with the one particular exercise they have. And so there's a philosophy of self-management, not only during, but also after. We all know that the low back pain or neck pain, it is episodic in nature and it is second to cold and fever. So we know this is going to come back and that's what is told to the patient. We will not be able to treat you, permanently off with the back pain. No, it's going to come back. So if it's going to come back, what's the difference when you're treated by the McKenzie method? The difference is that you are going to learn how to self-manage. And that means that if the pain comes, you know exactly what to do, what to stop, what are the exercises you need to start with, what is the dosage that you have to start with, look for 3 to 4 days. And if you're not better, then you come back. Most likely it is that the patient is able to be self-managing by themselves because they don't need to come back. So that also activates their confidence level. Now let's look at the drivers of pain, and these would be nociceptive. And when you're looking at what are the inherent drivers of pain that will be there in these type of patients, nociceptive would be more in terms of a referred pain that may be there. And we know high pain levels can also be a driver to pain and disability. So it could be a neuropathic pain, which is a radicular pain high on the VAS score or the NPRS score. A nociplastic pain could pain could be when there is more of a reorganization of neurons in the brain, and the problem is more of a processing of pain than anything else. And we are looking at cognitive factors, which could be very often the beliefs that the patient has got, expectations that the patient has got, the perceptions of illness, fear that is there, catastrophization, or a low efficacy. Emotional could be so often what you identify. Sometimes they are very angry. They even shout at us. They might be angry with themselves. They are angry with the system. They are angry with getting further and further treatments which is not really helped them. So they're feeling slightly better, but not really got fully better or got back into full functions. So they could be crying in front of you. They could be angry with you. They could be unwilling also to be evaluated by you. They could also be angry with you for asking them questions. There could also be it could also be due to comorbidities. The comorbidities could be two. One could be where it is a mental comorbidity, where they are into depression or other mental illnesses where they are under treatment. It could also be contextual in nature. Now, contextual in nature would be where it could be where we can maybe have a role to play, or we may not be able to make an effect there, because if it is something which is more with an employee-employer relationship or interpersonal relationships that the person is going through, which is playing a role also in their pain, these sometimes could be affected by us, some could not be affected by us. So these are patients where sometimes they might also need to be referred for a multidisciplinary treatment as also a treatment by us. So MDT would also, the difference is that we recognize within the McKenzie method that nociceptive, neuropathic, and nociplastic, these could be inherently present within the same patient. So we could have all these drivers in the patient, in a particular patient, as also within the particular classification. And we have got to hence identify whether we will be able to handle it properly within our system, or would we also need to refer the patient for a multidisciplinary. So if there is a nociplastic pain also there, which requires help from, let's say, to a psychiatrist or to for counseling purposes, then we may need to refer the patient. Also, if there is a neuropathic pain which is not getting completely better with us and we have labeled them as a non-responder, we would need to refer them to a pain physician and then get back and together treat the patient for better outcomes. So we recognize that all of them can be inherently present with the patient and helps us to really compartmentalize the treatment and make the patient very, very tailor-made for the patient. So this would be once again just a revision what the various pain is. So how would we really treat the patient and identify these barriers to recovery, and how would we use this within our assessment system? Let's look at it a little bit more in detail. So throughout the history, we would first identify the barriers to recovery that are there. So often the patient is off all leisure work. Leisure only because he fears it, not because that he is actually the leisure activities is worsening him. So this would we would identify, is there any barriers to recovery that are there as we are evaluating the patient within the history. We would also get the patient involved in the history, also thought processes, because he is problem solving and telling us there are questions that we would also ask the patient, which would lead us to understand, is there a barrier to recovery? So often the patient might say that the leisure activities, yes, walking does increase my pain. And so I have stopped walking. And then when we come into the better worse session, and in the history taking, and we look at, okay, what does walking do to you? We ask a question in a different way, and the patient very clearly indicates that the patient, as he gets up and walks, then the leg pain reduces and goes away finally. And then we go back and tell them, well, you told us that when you go for a walk, your pain increases. So what happens? When does it increase? And then as we question them further, we get them to understand that probably it's not the walking, but after you come back from the walking and after the activities that you've done at home, and the position posture that you have taken prior to your increase of pain is what has increased your pain. And so do you think that walking increases your pain? That gives them a positive feedback, and not only getting them to problem solve the next time, and also get them to come out of the fear and probably attempt that walking as a leisure activity again. So this would be handled all through in the various stages of the history, structured history that we have. And further to which we would go into the physical examination. We would identify any mental comorbidities that may be there during the evaluation in the history itself. And that would also be taken into account. And when we are physically examining the patient, we are going to be looking at how can we be examining the patient. Are we going to be very vigorous with the patient? Are we going to have a gentle approach with the patient? Or are we going to be getting the patient more involved with questioning the patient and problem solving with the patient all through the physical examination? So there could be a patient who would say that my leg feels weak or my arm feels weak, and then when we look at the neurological part of the evaluation and we say, well, what do you think? Do you think you are weak? Your neurological status seems to be quite good. And that could be where we are asking the patient to keep answering us and problem solving and coming to the conclusion that yes, they are far better than what they thought they were. And this helps us to handle some of the thought processes that they could have of an illness behavior or catastrophization, etc. Once we come into the physical examination, we do a movement log session, which once again is very where a patient is involved in it. We ask the patient, would you like to bend once and show us? Not just order the patient in a very paternalistic way. So getting the patient actively involved in the movement loss and in the repeated movement test. So once we have got the repeated movement, and once we have come to a diagnostic classification, there could be various structures that could be there. Either we've got a directional preference. Yes, 80% of the patients will have a directional preference. We know that from research. And if they have a directional preference, then they would be managed differently. It could be that they fall under the dysfunction syndrome or postural syndrome, or it could also be that they fall under the other or a chronic pain syndrome, which could be in the other subgroup. We've got various subgroups, and chronic pain syndrome is one such. So chronic pain syndrome would be where we are looking more at a nociplastic plane, where we need to refer the patient for behavioral therapy, where multidimensional therapy would be needed. Multidisciplinary treatment is needed. So if we have a directional preference we have identified, then the patient would be doing just that one directional preference exercise. If it is a dysfunction, then the management is very specific to the syndrome, which is remodeling. If it is a postural syndrome, then it is very specific to the postural syndrome, which would be more in terms of an education in terms of the postural syndrome, and also what would we do to break that behavior of the posture that has given them the postural syndrome. Now, if it is a chronic pain syndrome, then we would refer the patient for a multidisciplinary treatment. Plus, what we would do at our end is an evidence-based functional exercises that we would do. So what happens with all of them, whether it's a directional preference derangement, whether it's a dysfunction or a postural syndrome, or whether it's an other subgroup where we've identified a chronic pain syndrome, we would have very individual patient education. So the patient education in each of these subgroups or the classifications are going to be entirely different. And so a patient gets not just one blanket of a patient education, but a very specific patient education program, which would be very specific not only to the classification that they are in or the subgroup that they are in, but also in the learning stage that they are in, also the learning style that they are in, and also what are the various drivers that we have identified in them. And let's see, so if you have got a directional preference in a patient, then we are expecting a very fast response. That is, these patients will have, it will be a rapid response as compared to the others. But if you are going to look at that subgroup of patients who has got no direction, who has got no drivers to pain and disability, they will respond faster. And this subgroup of a chronic pain with several drivers to pain and disability that can counter the outcomes, they will have a faster response, but they will take longer than patients without barriers. Well, a patient who is a chronic pain syndrome will be slow responders. And yes, how does a patient, let's go to the next slide. How does a patient really, MDT clinician really recognize these influences in the patient? We'll look a little bit more in detail. We would interpret the patient's responses during the assessment. So every response that the patient is giving during the history taking and during the physical examination, which includes the posture, the not only just looking at the posture, but what is his response to when we are correcting the posture, and how does the symptoms change. These are very positively incorporated within the patient is in a educational mode, and this would be utilized also. So the patient's responses, as also we would, the responses that we get from the patient would be interpreted very with high clinical reasoning during the history and also during the examination. And we would take into consideration also the comorbidities to mental health. So for example, an SLR would be tested differently if a patient has got several comorbidities to mental health, several drivers. If you're going to check the SLR in the usual manner that we check, probably we might not get a proper answer as to what would be, is it negative, is it positive? But we could test it in different ways, like make them sit down, ask them to just extend the knee. So we would take into consideration the commodities to mental health, the patient's response that he's been giving during the history taking, or even during the physical examination, and then maybe change the examination to suit them. We would also clinically interpret. So often, if you see, the symptoms are modulated. And in these patients, we cannot really rely on those symptomatic responses. And so we are going to look at the mechanical responses, which will be movements and functions. And we are going to coordinate and see, is this mechanical responses correlating to what they are talking to us about the symptomatic responses. So these are interpreted very much. And then we would personalize the management further to this. And so the drivers of pain and the disability would be very implicit within the MDT classification. The comorbidities are noted at the end of the history. So the assessment form, in the assessment form below, all the drivers are noted. An example is given below. And we would also write down a short note of what the patient feels, like, for example, believes that pain indicates damage, the rest will heal, fearful of movements, work may worsen, there's an illness behavior, there is catastrophization. These would be, for example, noted.
So thank you so much, ma'am. Thanks from the entire team of Physio TV as well as Sancheti Institute of Physiotherapy.
My pleasure, always.
Yes, ma'am. We also would like to thank our chairman, Dr. Parag Sancheti, and our executive director, Manisha ma'am, and as well as our IT team, Mr. Tushar, for helping us with this recording as well as presentation of this Physio TV talk. So thank you, ma'am.
Thank
and
you
as
so
we
much.
wind up, yes, thanks a lot.
Bye.
Thank you, ma'am.